All right, let's just jump right into this explainer, because today we're putting you smack in the middle of literally one of medicine's highest stakes diagnostic challenges, chest discomfort. I mean, it's one of the top reasons people rush to the doctor, right? But it is also this incredibly complex puzzle. Why? Because hiding somewhere inside a massive pile of everyday, harmless causes is a tiny, tiny minority of absolute life threats that you simply cannot miss. So let's unpack exactly how medical pros actually solve this high-stakes mystery step by step.
To make this really concrete, picture this. A 55-year-old man walks into your ER. He's clutching his chest, he's sweating, clearly in a lot of discomfort. So what do you do first? Well, we're going to walk through his case using a very specific rule-out framework. See, the immediate goal here isn't actually to figure out exactly what is wrong right this very second. Actually, scratch that. It's more like we want to systematically separate the absolute deadly emergencies from the benign, can-wait conditions.
And just to wrap our heads around the sheer scale of this challenge, look at this number, 6 to 7 million. That is how many emergency department visits happen for chest discomfort in the US alone every single year. The volume is just immense. And get this, over 60% of these patients end up being hospitalized for more testing. The time, the money, the resources poured into this single symptom, it's absolutely massive.
But here is where things get really surprising. Now, our absolute worst fear is always ischemic heart disease, right? And yeah, that accounts for about 31% of cases. But a massive 42%, they turn out to be completely simple gastrointestinal issues, think like bad acid reflux. Another 28% are just chest wall muscle aches. So the vast majority of the time, the patient is totally not having a heart attack. But the catch is, the entire medical system has to be completely designed around catching the ones who actually are.
Which brings us to Section 1, the emergency room triage, hunting for the killers.
Okay, back to our 55-year-old guy. Your absolute #1 priority in triage is hunting down the acute conditions that will literally kill him. You can't get distracted by the statistical odds that he probably just has bad heartburn. No way. You must systematically cross off what we call the Big Four. That's acute coronary syndrome, your classic heart attack, acute aortic syndrome, a tearing blood vessel, a pulmonary embolism, a clot in the lungs, and a tension pneumothorax, which is a collapsed lung. These are the killers.
And we differentiate these threats right out of the gate using some very specific clinical clues. Just notice the stark contrast here. A heart attack usually builds over several minutes, kind of feeling like this heavy, crushing pressure. But an aortic dissection, that is sudden, unrelenting. Patients often describe it as this horrific tearing sensation, ripping right through to their back. Meanwhile, a pulmonary embolism is also super sudden, but has what we call a pleuritic quality, meaning it sharply hurts way more when you take a breath. We use these specific descriptors to really guide the hunt.
Moving right along to Section 2, decoding the patient's history, the interrogation.
So during this interrogation phase, the exact pattern of the pain becomes our ultimate clue. We weigh these symptoms incredibly heavily. For instance, you know how everyone thinks of left arm pain? Well, get this. Radiation of pain to the right arm or shoulder actually dramatically increases the likelihood of a heart attack. It's wildly a stronger predictor than the left arm. On the flip side, if the pain is reproducible, like if you just push on the patient's chest and it hurts more, that actually significantly decreases the chances of a true cardiac event.
All right, Section 3, the physical exam clues, vital signs and vulnerabilities.
Now, it's absolutely crucial to realize that a totally normal, unremarkable physical exam definitely does not rule out a heart attack. A patient can look perfectly fine on the outside while their heart is literally starving for oxygen on the inside. So what we're desperately hunting for are hemodynamic consequences. Basically, signs that the body's plumbing is failing. Severe tachycardia and plummeting blood pressure? That points us straight toward cardiogenic shock or a massive lung clot. Conversely, dangerously high blood pressure? That's a classic, screaming hallmark of an acute aortic tear.
Next up, Section 4, essential diagnostic weapons, ECG and biomarkers. Okay, once we've grabbed the history and checked vitals, it is time to look inside the body. And our absolute first weapon is the ECG. There's actually a strict rule for this. You must slap on an ECG within 10 minutes of that patient hitting the ER doors to hunt for a major blocked artery. But here's the terrifying catch. The overall sensitivity of an initial ECG for catching ischemia can be as brutally low as 20%. Yeah, it misses a lot.
So, to catch what that ECG completely misses, we turn to the blood lab. We are hunting for cardiac troponin. This is the absolute gold standard biomarker. Think of it like this.
When heart muscle cells get damaged and start dying off from a lack of oxygen, they basically burst open, spilling this specific protein right into the bloodstream. If we find elevated troponin, well, we know with near certainty that the heart is actively taking on damage.
But wait, just having a high troponin level isn't quite enough to confirm an active heart attack. What we're actually looking for is a dynamic shift. If we test the blood, say a couple of hours apart, and we see a significant spike or drop in those levels, that tells us it's acute ischemia, a heart attack happening right this very second. But if the troponin is high but just perfectly flat and stable over time, that points us away from an active, right now emergency and more toward a chronic, long-term heart issue.
Which brings us to our final phase, Section 5, scoring risk and next steps, determining the patient's fate. Finally, all the pieces of our giant puzzle are on the table. We have to synthesize the history, the ECG, and those lab results to figure out exactly what happens to our 55-year-old guy. To take human error totally out of the equation, modern medicine relies on clinical decision pathways, like the heart or EDAX scores. By taking his exact data and plugging it into these formulas, we can calculate a hard, objective, mathematical risk of him having a major cardiac event in the next 30 days.
Now, if he falls right into the low-risk category on these pathways and his high-sensitivity troponin tests come back negative, this is his actual discharge plan. And guys, this represents a massive, massive shift in modern medicine. Historically, we kept these patients overnight, put them on treadmills for routine stress tests, just to be safe. But today, the evidence firmly shows that if they meet these strict low-risk criteria, we can safely send them straight home from the ED, totally skipping all that unnecessary and potentially harmful extra testing.
And by strictly following this protocol, these algorithms have achieved an astonishingly low miss rate for heart attacks, literally under 0.5%. We've essentially solved the high-stakes mystery for our patient today, safely and super efficiently. But, it does leave us with a really fascinating question. As our diagnostic algorithms and our lab tests get closer and closer to absolute mathematical perfection, what actually happens to the art of medicine? How will the role of a doctor's raw, gut intuition evolve in the emergency room of the future? Definitely something to chew on the next time you walk through those hospital doors.